Hi, I'm Natalie May, and I've put together this PK talk about emergencies in palliative care, which I think might be useful to healthcare professionals who see and treat patients with terminal disease. So whether you work in the ED or as a GP or even in paediatrics, give me the next 6.5 minutes and we might learn something. We're going to talk about hypercalcemia, SVC obstruction, spinal cord compression, pain control, fractures and hemorrhage. But before we do that, I just wanted to give some recognition to the awesome work of Brent Thomas from Canada, known on Twitter as Boring EM. He's written this fantastic blog post detailing a structured approach to palliative care patients in the ED. If you haven't read it, you definitely should. Just type Boring EM palliative care into Google and you should find it pretty easily. So why is this important to us? Well, it's easy to forget that a terminal diagnosis doesn't mean that the patient in front of you is going to die immediately. Not all patients with a terminal illness are in the terminal phase, and there are some significant causes of morbidity which are reversible. There's every chance that these patients might present to your practice or ED, and it's vital to know about these conditions and how to treat them, with the aim of prolonging life, improving quality of life, and relieving symptoms in this patient group to whom it really does matter. So let's talk about hypercalcemia. It's the commonest palliative care emergency. It's not PTH mediated. It's associated with an increase in osteoclastic activity. 40 to 50% of cases of hypercalcemia are associated with malignancy, and myeloma and breast cancer account for about 90% of these. Symptoms are unhelpfully vague, but it's useful to know that older patients are more likely to become symptomatic at lower calcium levels. Treatment's simple. The first step is to rehydrate with at least 2 litres of normal saline before giving bisphosphonates. If the patient is in anuric renal failure, you need to think about dialysis, and think about steroids where the underlying cancer is lymphoma or multiple myeloma. Normalization of the calcium takes between 3 and 5 days, and you may even see a transient rise immediately after treatment, so don't check the calcium for at least 48 hours after rehydration. Treatment normalizes calcium in 80% of patients within a week, but prognosis is poor longer term. The median duration for which the calcium stays normal following emergency treatment is just 3 weeks. So let's talk about SVC obstruction, or superior vena cava syndrome. This is associated with carcinoma of the bronchus in 65 to 80% of cases. So if we turn that on its head, about 3% of patients who have bronchial carcinoma will develop an SVC obstruction. There are other benign causes, but these are rare nowadays. Symptoms typically include dyspnea in the first instance, and some patients describe a sense of drowning. As the obstruction worsens, patients may experience some symptoms of raised intracranial pressure, like headache, visual disturbance, impaired cognition, and coma. And when you examine them, you may find a tachypnea, distended veins in the neck and chest wall, facial edema, upper limb edema, cyanosis, and papilledema. Like so many things in the ED, treatment starts with ABC because the swelling can be bad enough to cause an airway obstruction. Relieve symptoms by sitting the patient up and giving them oxygen, and manage anxiety and distress with small doses of opioids or benzodiazepines. Consider high-dose steroids like dexamethasone 16 mg a day for 5 days to reduce swelling as an interim measure, especially if there's stridor present, and refer the patient to cardiothoracics or respiratory medicine for radiotherapy, chemotherapy, and consideration of SVC stenting. Radiotherapy in non-small cell lung cancer gave symptomatic improvement in 70% of patients, lasting a median duration of 3 months. Studies have suggested that up to 17% of these patients can survive to 1 year. There are lots of causes of spinal cord compression, but it occurs in up to 5% of cancer patients, and of these, about 70% occur within the thoracic spine. Patients classically present with back pain, a root irritation, or a band of pain which is worse on coughing or straining. They might complain of weakness, stiffness, tingling or numbness. An examination may reveal a sensory level and weak or absent reflexes. 75% of patients have substantial weakness at presentation, but it's important to note that bladder and bowel symptoms occur late with any presentation of spinal cord compression, so don't take their absence as being reassuring. Patients in whom you suspect spinal cord compression from metastases should receive 16 mg of dexamethasone once daily in all cases unless there are exceptional circumstances, and should be urgently referred. Treatment may include radiotherapy, chemotherapy for chemosensitive cancers, or urgent stabilization surgically. After treatment, 70% of patients who are ambulatory at the start of their treatment can retain their ability to walk, and 35% of paraparetic patients regain an ability to walk. Even up to 5% of completely paraplegic patients will regain an ability to walk, so treatment's quite important. One of the most common reasons for palliative patients to present is due to uncontrolled pain, and not understanding the basics of palliative pain management can prevent these patients getting the analgesia they need. For example, a patient who takes 200 mg of MST twice daily is probably not going to feel the benefit of 10 mg of intravenous morphine for his or her increasing pain. The simplest way to work out a sensible amount of breakthrough analgesia is to add up the analgesic requirements of the patient in the preceding 24 hours. That is, all the long-acting opioids and the breakthrough doses. Convert the doses to oral morphine and then divide the total amount by 6, and that will give you a 4-hourly breakthrough dose, which you can convert back to the drug and route you need. When converting to and from oral morphine, use a conversion table like this one from York. Take particular care with alternative routes, remembering that subcut morphine is twice as potent as oral, so half as much is needed. Intravenous morphine is generally accepted to be 3 times as potent as oral, so divide an oral dose by 3 to administer via the IV route. Patients with terminal illness, especially those with cancer, have lots of reasons to fall over and break bones, but be suspicious for pathological fractures like this one in a patient with metastatic breast cancer. Pathological fractures may occur in long bones with seemingly little force. Transverse fractures like this one are suspicious. You can also see lysis in the bone at the fracture site. It's not a clean break. Manage these patients with analgesia, initial x-rays and immobilization, but don't send them home to fracture clinic follow-up unless they insist. These fractures have far lower healing rates and often benefit from internal fixation such as nailing, radiotherapy or commencement of bisphosphonate treatments. Significant bleeding from erosion of a tumour into a major vessel or from esophageal varices can be a terminal event in patients with cancer or even non-malignant disease. It's unpleasant and frightening. Risk factors for major hemorrhage include abnormal clotting, low platelets, abnormal LFTs, NSAIDs, anticoagulants and tumour invasion. Manage these patients by talking preemptively whenever possible. Find out what they want in terms of admission or transfusion and have discussions about resuscitation orders. If they present with a catastrophic hemorrhage, it's usually all over very quickly, but where possible, warn the relatives. Use dark-coloured towels as these make blood less obvious. Give sedation for the patient in the form of IV benzodiazepines and consider tranexamic acid if they're not obviously irreversibly exsanguinating. Palliative care is an art in itself, and for the majority of patients, symptoms are managed over a long period of time. However, there are important reversible pathologies we might see in these patient groups, and I hope this whirlwind tour has given you confidence to see and treat these patients in your own practice. So long, and see you at SMAC.